So the first, there's just a few slides which I think I figured there would be some people who weren't on the one we did. We did a session in November, I think, and so there's a few very basic slides just covering some very basic background stuff, and then there's some cases. But I'm very happy. I mean, people should shout up and interject at any point, otherwise you get very bored of listening to me. So label tears. I know this is about FAI and label tears, I think, are basically the same. They're on the same spectrum. They sort of go together. It's very rare that people, in my experience, that people have symptomatic impingement and don't have a label tear or damage. Yes, thank you. Me neither. Or damage to the adjacent chondral cartilage in the same zone, because I think that's what causes the symptoms. We see lots of people with abnormal shaped hips and huge cams and big pistol grip deformities, and they don't have symptoms and they don't go on to develop any problems. And so the group that becomes symptomatic, that sometimes have lesser abnormal bone or abnormal anatomy, I think something happens and they get cartilage damage, be that labral or chondral, and that's what causes symptoms. So they're sort of the same thing. Clearly you see traumatic labral tears in patients who don't have FAI as well, but I think in FAI patients it's the labral or chondral damage that's symptomatic more than anything else. So the groups of patients who get labral tears, young patients with dysplastic hips because they've got enormous labrum and they walk on it, and that's what they weight bear on. Young patients with abnormal femoral anatomy. Now you could say acetabular anatomy as well, but it's more commonly femoral. Young patients with normal hips are traumatic, and then basically anyone over 60 has got labral tears. It's very rare that you do an MRI scan in someone over even 50 and there isn't some degenerative change, and they've nearly always got a labral tear. And I'm always wary of referrals of someone who is 62 and they're getting hip pain and they've got a labral tear and do they need a scope? Because nearly always the answer is no. We all know this, they're mostly anterosuperior. I think posterior labral tears are probably clinically insignificant. The onset of symptoms and the type of symptoms is really variable, and this is one of the problems with this, is all sorts of symptoms around the hips, and they might get, it's typically groin pain, but it can be lateral, it can be buttock, it can then come down the thigh. Sometimes people have mechanical symptoms, sometimes they don't. They get clicking, they often have psoas type symptoms, and their psoas tests are often positive, but that's because their psoas is just in that little triangle that you can see on that picture there at the top. That's where psoas lives. So if you've got inflammation in your hip just underneath psoas, then you're going to get some psoas tendinopathy, and there's a communication in about 10% of people between the hip and psoas anyway. So they're a really sort of variable bunch. And the trouble with this test, everyone says, oh, their impingement signs are positive, but so is everybody who has a painful hip. And so whilst impingement testing, I think, tells you that they've got soreness that's probably coming from somewhere near the hip, it's very non-specific. If they don't have a positive impingement test, conversely, it's relatively unlikely that their problem is truly impingement and or a labral tear. The Baton score, I think, is important, especially in females. We see a lot of females who are hypermobile and present with labral pathology with normal bony anatomy, and often they've got very thin femoral necks with big head to neck ratios. And they just get themselves into positions that they're not supposed to get into. And the treatment of those, whether or not they need surgery, is always much more along the lines of education, physiotherapy, muscle stability, to stop them getting into those positions where they're going to keep damaging that soft tissue. This I'll come back to, because this is what everybody looks at and says, right, well, you know, you've got cam impingement and you've got pincer impingement. You've definitely got those two broad types, but pincer impingement, I've put some cases together to try and show, is not just what it shows there. There's a whole gamut of things. There's a whole number of things that cause what everyone calls pincer impingement, and they're subtly different to each other. So an assessment of them, I'm sure you all know this, history examination, Standard imaging, just simple A-pin cross-table lateral is all that I get. It gives you an idea of the hip generally. You get an idea of version. The center edge angle gives you a clue as to whether they're over-covered or under-covered. For me, the group to look for are the under-covered ones, so the ones that have got a degree of dysplasia. Because especially if they're young and symptomatic, then they're a group that are quite likely to go on and do well from a PAO. So I think they're quite good to separate out early. And quite often I actually try not to arthroscope that group. If they're symptomatic and they're dysplastic, then they probably go and need to get their acetabulum sorted. MR, I don't do MRAs. I don't think hardly anyone does anymore. There was a vogue for doing that, but it doesn't really give you any extra information. The MR is quite good for telling you, for me, the general state of the joint, and particularly at the bottom there, any other causes of pain or symptoms. The MR is a bit of a screening test to make sure we're not missing something else. And the reason for that is lots of people have imaging evidence of FAI or labral tears, and actually that's not the cause of their symptoms. And so I think we still have to rule out other things. It's pretty good for telling you the alpha angle, which gives you a clue as to whether they've got a subtle bony abnormality. Ligamentum teres is largely ignored. And actually, I've had some very good results from debridement of the ligamentum teres in people who've had an injury and they've stretched it or damaged it. And on the MR, it just looks big and fluffy and upset with life in an otherwise reasonably normal hip. And actually, if you simply debride all that swollen tissue and the bits that are hanging off, they seem to do very well. And I think the ligamentum teres just gets trapped in the joint. If it's bigger than it should be and there's bits hanging off, it catches and it causes symptoms. So that's a group that do quite well. And so you get imaging that looks something like this, and this is pretty standard stuff. So relatively normal looking AP pelvic x-ray here with a nice sort of femoral neck and head neck junction offset. And then you get your lateral, and this is just completely flat at the front. And so this patient, this is running down here. This patient's clearly going to impinge in some position or other. And that's just a labral tear and a tiny little paralabral cyst in the same patient, which just gives you a clue that there has to be a labral tear here. The problem with MRIs for me is that the hip, you just don't see that much very well. The radiologists tell us, you know, they write reports that say things like fraying of the labrum. And I genuinely don't think you can see it well enough to pick up fraying of a labrum. You can see the labrum, you can see if there's a frank tear. But the correlation between what people think, me included, you see on the MR and what you actually see down the camera, it's pretty startling how different they can be. This is a screening tool I think is fantastic, and I wouldn't say all of my patients get this, but anyone who isn't absolutely balmed or obvious gets a diagnostic hip injection, which is just ultrasound, needle into the hip, fill it with local anesthetic to see what happens. If they are reliable and sensible, which is most of our patients, then I tell them what's going to happen. And I tell them they've got 2 or 3 hours after the injection when they need to tell me what it felt like. And the vast majority of people, 99% of people, come back and they either say, made no difference, doc, or it felt amazing. And there's very little in the middle, because it either numbs your hip pain or it doesn't. If there's a group of patients where you worry about their sanity, and if that's the case, I actually don't tell them what's going to happen. I just tell them we're going to inject their hip and we're going to see what happens, send them off for it and see them the next week and see what they tell you. Because I think there is a potential there for gain. So if you tell them, if this cures your pain, we're going to operate on you, or you have a definite problem, then there are people out there who it will cure their pain whether it does or not. So that little group, I actually don't tell them what to expect. And this,
Mark, Sandy here, sorry to interrupt. Just when you do that diagnostic injection, do you do pure local or do you put cortisone in as well so you get double benefit potentially?
I always do just pure local. And I accept the fact that then there are definitely times, in fact, I saw a girl last week who works as a nurse now, but she was at the GP practice where I do a clinic, where we do a diagnostic injection, it cures the pain, and then I send them back for a cortisone injection. So there is that possibility. But I've definitely had patients who react to the cortisone, and they say, yeah, I had my injection and then it was really sore, and an hour later I was really limping around, and that lasts for a day or two, and then it gets better, and then you don't get the information that you want. So I just do pure local.
Okay, thanks.
And then the imaging, now I'm hoping, so I used to use something called clinical graphics. I've now gone over to using HipMap, which is based off a CT scan. And this is a Stryker product. And I'm hoping that I've got one. If I do that, and that. So can you see that on my screen now?
Yeah, we can see your slides. You're not on big slide view. You're on small slide view.
Yeah,
you'll see it okay.
Why has it done that then? New share. All right, let me go to that one. How about that? Can you see it now?
Yeah, that's full screen. Looks great.
And that's you can see the hip rotating round.
Yep.
All right. So this is oh, I didn't mean to do that. This is the software, oh dear, from the HipMap, which I wonder if it's hiding. Oh dear, I'm not doing very well this morning. It's obviously too early for me. But you can see what it does is it colors in the bone, and it colors in where it thinks it's impinging. So this is based off a CT scan. And these, I think, are 0.5, 1, 2, 3 mils of excess bone. And oh dear, hang on. I'm trying to get back to the, there we go. Has that disappeared off your screen now?
No, we can still see it just in a smaller view with some graphics on the right.
Yeah, okay, so that should be okay. So let me just, sorry. All right, so what it gives you is it tells you over here, so you can see my mouse where I'm flicking around.
Yes.
Yeah, so it gives you the center edge angle, which is pretty just useful, but then it tells you the acetabular version, and it tells you the version in various different positions. And so you get a little map like this that it tells you the version of all of these. It gives you the femoral version, the neck shaft angle, and the combined version. And it very helpfully colors everything in for you, yellow, red, and green. This guy is interesting because he came to me actually for his left hip. And he said to me that his left hip's bothering him a bit. He can't play sport, but actually his right hip has become more of a problem. And he had his right hip scoped about 1.5 years ago somewhere else. And he said it's never really been right. And he had a labral debridement, not a repair, and a bit of a cam resection. And it's really interesting that you can see where they've resected his cam. And you can see the area that they've taken bone away, which is possibly from maybe here to here. And that's the deepest bit. But they haven't taken away anything here slightly further down the neck. And when you spin him round, you can see that they've sort of done that and missed this bit. Now, that's really easy to do. And this is one of the problems with hip arthroscopy surgery is assessing what bone you take away and where you take it from is really difficult. And we use x-rays intraoperatively. And you try and sort of take away as much as you can, but at the same time, you don't want to massively overdo it. And we've all seen x-rays or scans afterwards with a huge, great divot taken out of the superior neck. But this sort of software, I think, is really, it just is a good visual aid for exactly where you should be looking. The next step of this, and the software does exist to translate this to your II views in theatre. What you really need is for this data to be fed into the Mako robot, and then for the robot to control the burr, that it will only burr away this bone that you've planned. But I think that's a few years away yet. But this sort of software is, especially for complex cases, it's just really useful for identifying the shape of the hip, the angles that are otherwise reasonably tricky and time consuming to measure. And it's very nice to show the patients, and it's very easy to show him this, they understand this visual about it. So I think this sort of stuff works quite well. Now, what are my chances of getting back to my presentation? Resume share. Oh dear. you are screen sharing, new share. If I do
You're
that.
You're back on now.
All right, it's a miracle. All right, and then just before we get on to a case or two, so this is just a typical hip arthroscopy. That's the labral tear hanging down into the joint, and you can actually see the junction here between the torn labrum, and this is chondral surface that's damaged. This is not all labrum. When it comes back round, you can see the labrum coming around here, and then the articular cartilage. And this is pretty bad, but this is a wave sign, and it started to detach down at the bottom. And the wave is really just where something's knocking against the top of it's always a femoral lesion. The femoral cam hits the edge of the socket, it sneaks in past the labrum and then starts to grind down on the articular surface, and it peels off this articular cartilage. And this is why they're symptomatic. It's this damage, and it's not the bony lump, it's the damage that it's causing. And so in cases like this, you repair that back up, and here you can see the edge of the wave sign. So this articular cartilage was all folded down into the hip. And then you head off onto the outside and sequentially, so this is just flat. So you sequentially just burr that away so that you recreate a head neck junction. And that's a sort of typical thing. That just down there is the capsular repair. And this is something that's come in the last 2-3 years, 5 years maybe. Which is repairing the capsulotomies at the end. So that I think especially in females and especially in hypermobile patients, you have to repair the capsule, otherwise they get more instability after surgery. And then post-op, there's really, just like with physio, there's very little evidence for any specific physio regime for FAI type patients, this group of patients. There's even less evidence for what should happen post-op with these patients. And if you ask different people, everyone has different ideas about it. I know there are people around who put them on crutches for 6 weeks post-op and tell them not to wait there. I've never done that. I don't see the point of doing that. I think they need a week or two of rest, which basically it's the same as knee scopes. I tell my knee scopes to go home and sit down for 48 hours, just put their foot up, stick some ice on it and let it settle down. For these, I think they take 7 or 10 days of just go home and chill, put your feet up, walk around the house, but not much more. And then after 7 to 10 days, I think from there to 6 weeks is about avoiding any positions or movements that might damage the repair or damage the structures in the hip, but at the same time getting it moving. And so I like them to get on an exercise bike at 2 to 3 weeks with the seat nice and high and just do straight line exercises. You see patients with adhesions after this sort of surgery where the capsular labral recess disappears and it sticks together, then their labrum can't move and they get symptoms from that. And so I think they do have to get going, but you don't want them doing any side to side work, instability work, anything with too much rotation or deep flexion for at least that first 6 weeks. Now, I don't know why it's 6 weeks. It's a random typical orthopedic time frame. I don't think 5, 6 or 7 are any different. It's just we only work in 6 week blocks. And then you kind of step up from 6 to 12. I tell everybody that they're going to hate their hip from about week 7 to 10 or something. They like the first 6 weeks, they gradually get better, and then they step it up and they get worse again. And they just have to push through that and keep going without making it too sore, and then it will slowly pick up again. And it's a good 6 months before these patients are really happy. It's a long, slow recovery. They get there usually, but it takes time. So any questions about any of that basic stuff before we do a couple of cases?
Mark, with that rehab, and you got an elite athlete that has access to 24/7 rehab, are those recovery times any shorter or any different?
Yeah, they can be. I think for me, I think the first 6 weeks is an absolute. And the reason for that is that it's like a meniscal repair. It needs time for the scar tissue to form, for the healing to occur. The labral repair is basically all you're doing is putting a stitch around the labrum and hoiking it up and putting it roughly back where it should be, and then relying on the body to heal it there. And so I think you have to give them a good 6 weeks where you're not challenging that repair, you're not pulling it around. After the 6 weeks, yes, the elite lot get going a bit quicker. Invariably, they get cortisone injections somewhere along the way, often multiple times, so that they can put up with their symptoms a bit better, to rehab a bit better. But I think the elite athlete group, they have other advantages. Clearly, they're typically in much better shape before the surgery. And so their muscle loss after surgery is much more limited. And I think what they do different is in that first 6 weeks, whereas a normal person would do a couple of sets of exercises a couple of times a week if you're lucky, the elite athletes will be doing a couple of hours of exercises every day without fail, and they'll be in the pool doing hydrotherapy. So I think they lose a lot less in that first 6 weeks, so they can hit the 6 week mark basically raring to go, as opposed to everyone else who's gone back 50% before they then got to come forwards again.
I think if I could just comment there, like there's that variable irritability. If you get that case of the more elite person who's really on top of symptoms, not sort of pushing any irritability of the hip, well then absolutely you could just sort of step things up as quickly as you feel was appropriate. But I guess you still see those ones that have got that high variability who absolutely need all of their 6 weeks and actually can't as easily participate in all the things an elite athlete would otherwise be doing to ensure that they do get back sooner and more thoroughly. So I think it's just critical to really assess carefully week on week, where is their irritability at? What is the load that they've been putting themselves under, and really making those week to week adjustments.
Yeah, and one of the difficulties with that group is which is an advantage and a disadvantage for them, is their motivation is very different. So they're not just trying to get back to a bit of weekend cycling and the occasional game of soccer. It's their livelihood, and they want to get back to playing for financial gain, for social, for everything. And so there are definitely times when they will ignore some of those symptoms and just push through it. And often that's what they're used to doing. They have symptoms for a year before they get their surgery because they've been pushed to the end of the season or whatever. So they're used to the pain and they put up with it. So and then they overdo it. And then I think you're right, they get that irritability, and it's quite hard to pull them back sometimes. They just want to get on with things. All right, so this is an interesting case, and I think I showed some of this because this guy was pre-op in November. So this is a lad who is 17, 18. He was just about to start a course at uni, I think, and he got the typical 3-year history of right hip pain. And this is one of my bugbears about hip scopes, is that everyone seems to come and see you when they've had symptoms for a couple of years, and then you scope them and everything's trashed. And your heart sinks as a surgeon, and you just think, why was I not doing this 2 years ago before it was all trashed? But it just seems to take a long time to get through the system. But he pitched up with typical right hip pain, groin, buttock, thigh. It had got worse to a point where he couldn't do any sport, couldn't run. He was limping. He could walk, he said 20, 30 minutes, and then he could really feel it, and he was having a rest. Clicked, but no other true mechanical symptoms, no hypermobility. And he's a pretty sort of short, slim guy, very sort of normal average build, but obviously when I examined him, a very sore hip. Not too bad in a straight line, but any rotation, any adduction, any impingement sort of testing was really sore. And he's got a really interesting set of x-rays. So this is his plain x-ray. Now, this at first glance, so you look at this and I look at this and think, well, he's got a broad neck, and so you worry about his offset here, but he's got this huge overhang here on both sides. Really, they're very similar, and the posterior wall sort of comes up here. The easiest way to find the posterior acetabulum is to follow the ischium and follow it up, and that comes up there, and you can see it snakes up there. The anterior wall comes from the inferior side of the superior ramus, And so you follow that out here, and this is anterior wall, and that's anterior wall going up here. So here he's got this so-called crossover sign, where he's got this huge amount of anterior wall in front of the posterior. So this will get reported as showing a crossover sign, and that's suggested that he's got acetabular retroversion. But this is a supine film, and they often are. And if you take an erect film, it disappears. And now up here, there might be a little bit of a crossover, but it's really not very much compared to, if I just go back to there, you see how big this is down here. And then it virtually disappears when he stands up. But what happens when he stands up is that all of a sudden his femoral neck looks even broader than it was before. And so he's clearly got some bony abnormality there, but it's very hard. And the trouble with one of the issues surgically with this is, of course, when you arthroscope them, then they're not weight bearing, they're lying down. So their pelvis is probably in a slightly different position to what you think it might be. So assessing the impact of that anterior acetabular rim on the operating table is difficult unless you've got proper software and analysis preoperatively and you're absolutely sure of what you're doing. So I think his crossover sign virtually disappears. And the crossover sign has been written about a lot, and there's a lot of literature stating how good it is, and a lot of literature stating how variable it is, and some literature stating that it's pointless. So I'm not sure where we go with that, but I think more useful is probably a 3D CT with a 3D recon where you can actually have a proper look at the shape of the acetabulum. On his laterals, this guy's got a cyst here at the front of the femoral neck, and that's absolutely pathognomonic that he's been impinging. There's no way that you can get that unless it's been knocking against the edge of the socket. So I think that's one of the absolute signs that if you see that, and he hasn't got it on the other side. So we know that he's been impinging. His MR didn't look terrible. This is just to show his general version. So his overall acetabular version is pretty reasonable. Hello. His femoral version, he's a little bit not quite neutral. Ordinarily, you'd like people to have a little bit more anteversion than that, but he's not bad. And then on his MR, so you can see there's some reaction at the head neck junction there, which is probably where that cyst is. And then up at the top there, oh, I don't know if I can, let me just pause that and run it back. Up here, you can see that there's clearly a lot of upset. This is chondral surface coming around here. That's the edge of the bone. This is the labrum. This is the chondrolabral junction, and it's very upset with life there. And so we're expecting to see some damage inside this hip. And he's clearly got a labral tear, and you can see fluid coming all the way through here. So his labrum's obviously torn as well. And so not surprisingly, when we scoped him, the front of his hip looks terrible, and it's all red and inflamed and upset with life. And this one down here, bottom left, shows really nicely that he's got the labrum itself is red and inflamed, and there's a bit of an interstitial tear, but it's not so bad. This is the chondral damage underneath. And when they get to this stage where they've been impinging for 2-3 years, the articular cartilage bears the brunt of it. And there's not very much you can do about that arthroscopically or open. It's just damaged cartilage. It doesn't grow back. And so, so you repair the labrum as best as you can and tidy this up. And just hope that nature does the rest for you. So essentially you end up with this sort of situation with 2 or 3 anchors and stitches up here, and then you tidied this up and just hope the body does the rest. This is just the sort of favere at the bottom, the ligamentum teres up here. And then you come out into the peripheral compartment, and I've just denuded the articular cartilage there, and this is his sort of the edge of his cam coming down here. And then you just sequentially burr that away. That's just another view of his ligamentum teres. So the group that have an LT injury, instead of looking like this, you often see the actual ligament. So that's covered in synovium. You can't really see it. And what you can do is you can IR and ER the hip at the same time, and you can see it unravel, and it kind of winds up and unwinds. If they're ruptured or they've got a real problem with it, you actually see the fibers of the ligament and they're sort of sitting up like little strands of spaghetti, and there's bits all over the place. And if you just debride it back so that there's nothing catching, then that's, I think, quite successful. And so that's him towards the end of our debridement. We just sort of take all of this away. His outlook is not terrible. I think symptomatically he was much better by 2 weeks. He was very happy. He's about 5 weeks now. But I don't know what the long-term outlook is for a hip when they've had that amount of chondral damage at his age. So now he's also in the group, the young male 17, 18-year-old that in sort of genetically we're not that bright at that age. And so he will undoubtedly go and do silly things as his hip feels better. And so I don't know how well he will rehab over the next few weeks. We'll just have to keep an eye on him. I will let you know.
Mark, sorry to jump in. That again, return to sport from that with the debridement of the cam lesion. Is that 6 months? So
no, not. I mean, it's very variable. I mean, I think that the cam itself doesn't really change very much. I think if you're in a bizarre way, I think if you take away a decent cam, I almost feel happier with them going back to sport earlier, because I feel like I've created a better mechanical situation for the hip. If there was no cam and you haven't changed the mechanics of it, I worry more that you've got to protect it even more, because the situation could arise again that caused the damage in the first place. I tell myself in him, I've got rid of that situation, therefore it shouldn't happen anyway. So he will get the same 6 week sort of period of trying not to do too much and just let it settle down, and then just rehab slowly. And as soon as he's happy, he can go back. Typically back to social sport is somewhere between 12 and, for him, it'll be 12 and 18 weeks in that third 6 week block. And then hopefully after the sort of 18-week period, he should then slowly just step that up. So it should be a bit earlier than 6 months.
Thank you.
So this girl's interesting. I saw this girl in clinic this week, but I met her a couple of years ago. Now she's a bit older, but I put her in because she demonstrates two different things that I'll show you. So when I first saw her, she's 47, 3 years. There's a theme with this 3-year history. Maybe that's what they all just say, I don't know. So 3-year history of typical groin pain. In her, it was just certain times through the day, it just kept happening. It wasn't really specific movement. She was just describing every now and again, it would just catch and be really sore. It lasts for not very long, a few minutes, and then it would go. But it just kept happening and happening and happening. But clinically, she was typically, as I ever saw, in deep flexion and impingement signs. Her other hip was at that time asymptomatic, but she became symptomatic on the other side pretty shortly after I first met her. And she'd had lots of physiotherapy, no injections. But this is her plain X-ray. So the right is the symptomatic side, which on there looks the better side of the two. And the left side, which wasn't bothering her until I told her it should do probably, she's got this funny thing here, which she doesn't have here. She's also, for those of us that are interested in pelvis and the sacrum, we've got she's got sacralization of L5 up here. So she's got a block of bone there that she's not supposed to have, which means her L5 nerve runs through a canal here, which it's not supposed to do. And that also means that she's at risk of getting SI joint problems and therefore all sorts of other problems. And you can see that her symphysis is not enjoying life much either. So she's got a few other things going on. She was also, I'm trying to think what her weight was at that point. She was probably 110 kilos or something. So she's quite a big girl. Which also interestingly makes hip scopes very challenging. The distance from the skin to the joint is in a thin patient is a good 10-15 centimeters. So as soon as you get a patient with bigger hips, it actually gets very tricky. Once the length is the length of the cannulas, when it's all the way in, you have no maneuverability. And so even at a BMI over about 30 starts getting hard. So once they're up to 35 and 38 like this, it gets tricky. But this is where I get into the discussion of this model of cam or pincer. And everyone assumes that a cam is you've got excess bone here, a pincer is just that you've got some excess bone here. But the pincer side of things, that's really simplistic. And I think it's where we were 10, 15 years ago, but it's not the case now. And there are multiple different causes of the so-called pincer impingement. And so you get hips like this. This is basically just a global over-covered hip. So keeps doing that. So this is over covered. You can see the anterior and posterior walls are right over here. So this will get called a pincer impingement. And it's a type of pincer, but the whole hip is over covered. And so there isn't one area that you can debride that's going to make that any better, or one area where you can take away bone. That's just going to be a stiff hip, and they're going to get arthritis. They've already got a bit of arthritis, especially on the right side. So that's one type of impingement. Now this is her CT scan, this girl, and on the right side, which is the symptomatic side, she's got a sort of impingement that's really a subspine impingement. So her anterior inferior iliac spine is low and just keeps going. So there's no recess here. What should happen here is that should recess in, and the acetabulum should be much shallower at that point. But she's got a subspine impingement there. And so she's got a relatively broad area where there's excess bone covering that femoral head. And the problem area really is all of that. Whereas her other hip is different. Her other hip, she's still got some subspine impingement. But what you're seeing on the X-ray on her is this little thing here, which is beyond the spine, and that's actually labeled ossification. So she's got subspine impingement and she's ossified some of her labrum. And these are all different types of pincer impingement. So the subspine is relatively uncommon, but you see it. Labral ossification is something that typically affects an older group. She's the classic person that gets labral ossification. They're 20 years older than normal hip scope patients, and typically female for some reason. And if you look at her MR, the MR on the right side, this is just under the ACIS, and you can see the bone comes down to here, and then the labrum is here. It's separate, but there's no space here, and that's clearly going to impinge against that and trap that poor labrum at some point, because this bone finishes here, and it should finish back here somewhere. Whereas when you look at her other side, the bone comes all the way down here, and there is no labrum. So the whole labrum is ossified. And I think that's probably her normal acetabulum, and this is ossified labrum. And they're different. They present the same way, but they're subtly different. And this situation, you can imagine that you can take away some of this bone and you can repair that labrum back up, and that's probably going to do okay. Whereas this situation, if you take that bone away, which you have to, there's a tiny shred of labrum down here, but there's really not much left. And so the outlook for this hip, I think, is worse than the subspine impingement. Now, even better than that, if you're lucky, you get a patient with just a little bit of anterior wall that overhangs at the front. So the young chap that we saw at the beginning, he's probably just got a little bit of excess anterior wall. And that group is fine, because you can just take the labrum off, debride it, put it back on, they do much better. But they all get called pincer impingement, and they're all different. So in her, this is her right hip, and you can see it's completely trashed, that labrum. I mean, there's virtually no normal labral tissue left. It's absolutely shagged. And then here, it doesn't show particularly well, but this is capsule across the top. So iliopsoas is probably just beyond that picture there. This thing here, that's the bone. That's the subspine impingement. And this is the labrum down the bottom. And the bone is growing over here. Sometimes it comes all the way out here, and it actually sits right over the top of the labrum. And you can just take a burr. So that's there. This is a little bit further on. And we just burred away some of that bone. And then you just keep burring and burring until you leave some labrum behind. And then you repair the labrum back up. And it always looks a bit rubbish because it's spent the last few years being sucked down, pushed down by the bone, and you push it back up, and then you get all this chondral damage underneath. That just showed it a little bit clearer. This is a different case, but you can see the bone coming down and sitting on top of the labrum. This one didn't have quite as much damage inside the hip, so you just take a burr and burr it away. And then the labrum, this group of patients, if you get them early, do really well. because their labrum has spent the last 5 years being squished between two bits of bone. You suddenly take one away and the labrum feels great. And almost overnight, they feel better, this group. So they like that. But if you get them before they've got terrible damage in there. And then that's her other side, stop flicking around, where again, you can see she's really inflamed. And this is slightly earlier, I think, on the other side, but she's still got this chondral damage. This is articular surface that's being ripped off, that's sitting underneath the labrum. And so on this side, by the time you take away all the bone, there's really not much labrum left. That's the articular surface there, just sort of falling away as opposed to sitting underneath. It was really just to show a couple of different types of impingement. And then this is just another example of yet another way that patients get what gets called pincer impingement. So this is a 25, 26-year-old chap who's a professional sportsman. Now he'd done what they always do, which is try and get through to the end of the season. So he had about 16 cortisone injections on a bi-weekly basis to settle down his symptoms. And keep on playing, obviously constant physio and hydro. And had done all right, but I was shocked. He came in and got on the couch and I couldn't even flex him to 70 degrees without him wincing. And how you ever play even social level sport, let alone professional level sport, with a hip that sore, I do not know. But their motivation is not normal. They're not a normal group of patients. And his x-ray, his plain film, the right side is a symptomatic one. His left side looks a bit dodgy with this sort of, I mean, this may well be ossified labrum around here, but it doesn't show very well. But on here, he's clearly got some early degenerative change at the head neck junction on this right hip. But on there, this is an os acetabuli. So there it is on his CT scan. So he's got a big loose fragment of bone and he's got a huge cam here. Now, the etiology of this, no one really agrees on. It's probably just degenerate bone formation as a response to persistent impingement. I mean, he's got a subspine impingement as well. There's no space here. So he's got a big cam, he's got subspine impingement. The labrum here is going to be in trouble. And this is just a reactive phenomenon. But of course, it causes even more impingement. I think sometimes these are small and they're there from birth and it's a developmental thing. There's also a theory that some of them represent little fractures and it's a fracture of the edge of the acetabulum. And there are definitely cases where you get a CT scan and you can see that there's a clear line. Now here's, let me just go past that. On his MR, the os is here, the labrum's there. And here, that to me, I don't think that's a fracture from that. But you see somewhere it sits here and there's a clear fracture and a clear big piece of bone. And that group, you can actually fix them back on. And they don't do too badly. But I think with him, this doesn't need fixing back on. It's just not supposed to be there. So that needs to go, this needs to go, and then the labrum needs repairing. And inside the hip, I'm going to flick through this because I've got the mother of all this today, so at some point I need to go. There's his labrum, and again, it's just completely trashed. And more worryingly, this isn't very clear, but the labrum's up here. This is a probe. That's the femoral head. That is all his articular cartilage off his acetabulum, just completely folds down. And you can just about make out here the edge of his wave sign. All of that articular cartilage is not attached to the bone underneath, and it's just been consistently scraped off. And so you can try and fix this dog's dinner of a labrum, and you can get rid of his os and his impingement, but you can't do anything about the articular cartilage that's no longer attached to the bone. So that's the os there. So this is the labrum, the hip's over on the right. And that's just this huge big lump of bone that's sitting up there. And so you just take a burr and get rid of it and just burr it away. That's his labrum hanging into the joint. And so you fix all of that and then you take away his cam. So you do this on the lateral view on the x-ray, and you start with what was flat and you just reshape that and try and make it look like a sphere. And he's done all right. He's got back to playing, but I like all of these people, he will get back to playing. His career will be no doubt cut short because eventually this will come back to get him. But then he'll be struggling in his 30s, and he'll be one of the patients that ends up with a hip replacement in his 40s. And the sort of disappointing thing again is that I think if he'd have had this a year before, you might have not seen that damage to the articular cartilage, The labrum's by the by. You can fix the labrum. If you have to, you can do a labral sort of not transplant, but reconstruction and reconstitute labral tissue. That's not the end of the world. But when you see the articular cartilage is peeled off and is trashed, it's really disappointing, and there's just not much you can do about that. People are trying. You can microfracture the acetabular surface, but it's hard. And the results are not great, and people are trying glue and like fibrin glue to try and get it to stick back on, but there's not yet any really good results for the articular damage that you see. So I think if I was going to give a message to people at all, it would be that ideally that as a hip arthroscopist, we need to see these people sooner in the process, not 2 or 3 years down the line when it's a bit too late, really. But there you go. Questions about that? You've all gone quiet. I reckon I might be done. I have a list from hell today. We're getting all the public trauma now for the next 3 months at Calvary, and so I've been inundated with very unwell, unsavory patients.
Sounds tough. Great talk, Mark. It's absolutely terrific.
Excellent. Thank you.
That's right. It's a pleasure. And if anyone happens to be free tomorrow and wants to give me a hand with some fractures, I suspect I'll be busy. By all means, give me a shout.
Mark, can I just ask, is your clinic open for fractures on Monday afternoon? Is that right?
Yeah, so I'm always there on a Monday around either mid morning onwards or late morning onwards, and every Monday afternoon. Yeah. So
terrific. Great.
I think because now there's Arthur and Basil. Do you guys know Arthur and Basil? Arthur are both upper limb surgeons. So they just joined WOC. So because they're now here and actually physically located in the clinic as well, I think what we're going to try and do is go to a system where every day there is a clinic at a certain time. And then it just gives people the option to say, right, Monday to Friday, we will cover a fracture clinic here every single day. And then you don't really have to think, is there going to be someone on that day? We'll just make sure we cover it every day, and one of us is here to see the fractures or the injuries. And even if it's me and it's a complex upper limb, we can see them and image and triage and then pass it on to the right person, or same for lower limb and stuff like that. I think that would be a better service to offer than say we're here random, some weeks 2 days, some weeks 3 days, etc.
And Mark, on Monday mornings, can the patients ring your rooms before 11 to speak to your secretary to get an appointment that day? Yeah,
or even just rock up, to be honest. Most of the time, when ED ring me on a Saturday or a Sunday, I often just say, look, just time to come at 11 o'clock, doesn't matter, and we'll fit them in.
Okay, that's terrific. Thanks for that info.
All right, well, enjoy the rest of your day and your weekends.
Thanks, Mark. That was terrific.
Yeah, thanks, Mark.
Thank you, Mark.
Thank you, Mark.
Ciao.
See you. Bye.